Thank you very much, Dr. Gridelli and Dr. Garasino. It's really nice to be in person here after having done this conference for the last 2 years virtually. And I must say, I always get impressed with how Dr. Mock looks perfectly fine, whatever time of the day it is in Hong Kong, day or night. Anyway, so my task is to talk about chemo IO. These are my disclosures. And before we get into the data, the question is there any rationale to combine chemotherapy and checkpoint inhibitors, or it is just a combination of two active agents? And there is at least some preclinical evidence that chemotherapy may have pro-immunogenic effect, in that chemotherapy can release tumor neoantigens, can cause the release of DNA into the cytosol and initiate activation of the STING pathway. Interestingly, can also activate dendritic cells and antigen presentation to effector T cells. And on the flip side, can downregulate Treg cells and type 2 macrophages. Interestingly, this effect of causing a more pro-inflammatory tumor microenvironment phenotype may be different based on the type of chemotherapy. So this is data suggesting that pemetrexed may be more effective in causing such an environment compared to paclitaxel or carboplatin. One needs to be reminded that this data is from Lilly investigators. And of course, what the relevance of this data set is in patients is unclear, but there does appear to be some rationale, preclinical rationale, for combining chemotherapy and immunotherapy. And the first study that truly assessed this was KEYNOTE-21G, a randomized phase 2 study that compared, that enrolled patients with advanced non-small cell lung cancer to chemotherapy with or without pembrolizumab. And this study demonstrated both overall and progression-free survival advantage and formed the basis for KEYNOTE-189, the phase 3 randomized study that randomized patients to chemoimmunotherapy versus chemotherapy and placebo with pemetrexed, the platinum pemetrexed as the chemotherapy backbone. It's important to note, and I can tell you that at least in the US, some community physicians still discontinue pemetrexed after the first 4 cycles. It's important to note that the pemetrexed maintenance was continued in the experimental arm. And as is well known, this study did demonstrate overall survival advantage with a hazard ratio of 0.56 that translated into a median survival of 22 months with the addition of checkpoint inhibitor to chemotherapy. And then what is even striking with this regimen is that the benefit appears to be across PD-L1 subsets, though there does appear to be some suggestion that the benefit is greater with PD-L1 expression as compared to in patients with tumors that are PD-L1 negative. Now, it's important to note the adverse event profile when you combine different agents. But what was what was observed was that you don't necessarily see more toxicity with either agent, in that you see the same incidence of adverse events with cytotoxic chemotherapy as well as with checkpoint inhibitors, and you don't see an increased rate of either of those two sets of toxicities because you're combining. And clearly the rate of toxicity is greater because you're giving more treatment, but the overall incidence of different toxicities is not different. One toxicity that is different with this combination, and this is particularly with platinum pemetrexed and pembrolizumab, is renal events. So the incidence of acute kidney failure is 5.2%, and the incidence of nephritis was 1.7% with this triplet combination. It was far lower in patients who received chemotherapy. One sort of practical point to this is that I'm quite mindful of using contrast when getting restaging CT scans, particularly in patients who have been on the maintenance part of the triplet regimen for a period of time to minimize renal exposure to IV contrast. So after the data in non-squamous patients, KEYNOTE-407 evaluated the same concept in squamous cell patients, and the chemotherapy backbone here was carboplatin, paclitaxel, or paclitaxel. And this study also showed a survival advantage. And now 2 years, there was an improvement in survival of about 7%. But in this study, and this data was presented by our next speaker, Dr. Pazares, and in this study, there did appear to be some difference based on tumor PD-L1 expression, in that the benefit appeared to be greater in patients with PD-L1 expression greater than or equal to 1%, whereas in patients whose PD-L1 expression was less than 1%, there did not appear to be as much of a benefit, with a hazard ratio of 0.79, which did cross 1. Now, this is retrospective subset analysis, and therefore needs to be viewed with caution, but there does appear to be some difference based on histology and regards to PD-L1 expression. It's interesting to note that this is different than the IO-IO combinations, and I'm sure Dr. Pazares is going to cover this in the next presentation. But just in the context of PD-L1 expression, and this was data presented by Dr. Ramalingam at ASCO in 2020, and then subsequently updated by Dr. Pazares in the JTO publication. So this is a 3-year update of Checkmate 227. And what this study showed, that even though this combination is approved in the PD-L1 positive patients in the US, in the PD-L1 negative patients, the benefit was even greater. So the hazard ratio was 0.64 in the PD-L1 negative as compared to hazard ratio of 0.79 in the PD-L1 positive. But then when you look at, according to histology, the benefit was even greater in squamous cell patients. Now, this is retrospective subset of a subset analysis, and I'm sure Dr. Garasino is cringing on me sort of slicing and dicing this data. But nonetheless, a suggestion that PD-L1 expression in histology may have relevance in choosing frontline therapy. Interestingly, similar data was observed in the Checkmate 9LA study, where the IO-IO combination was combined with chemotherapy. And again, in the PD-L1 negative patients, in the line at the bottom of the figure, there was a differential efficacy based on histology, in that the non-squamous cell patients appeared to who had PD-L1 negative tumors appeared to derive a greater benefit than patients who had non-squamous histology. Now, Dr. Mock discussed about PD-L1 high patients, and he made a very good point that this is somewhat of an arbitrary cut point, but this is sort of the biomarker that we are now utilizing at the present time to decide on IO therapy. And so these three somewhat artificial subsets have emerged of PD-L1 less than 1%, PD-L1 at 1 to 49%, and PD-L1 more than 50%. And as Dr. Mock presented the data of the FDA analysis of more than 50% that was presented at this year's ASCO, at last year's ASCO, the same group led by Dr. Attenborough presented the data on non-small cell lung cancer patients with PD-L1 expression of 1 to 49%, where they pooled the data. And I know that some statisticians have some reservations about such analysis, and therefore this analysis needs to be viewed in that context and should be considered more as hypothesis generating rather than as conclusive evidence. But nonetheless, what this analysis showed, that the outcome appeared to be better with chemo-IO as compared to either IO alone or IO-IO combination. And therefore, generally in this patient population, there's a preference to use chemoimmunotherapy. And how about patients with PD-L1 high that Dr. Mock reviewed extremely well? And I'm going back to the FDA analysis that was presented at this year's ASCO. One point I just wanted to highlight that Dr. Mock did show, that the response rates did appear to be somewhat better with chemo-IO, and there did appear to be some difference in progression-free survival, even though there was not a significant difference in terms of overall survival. And to me, I do tend to use this data to choose chemoimmunotherapy in these patients who have high tumor burden, such as multiple liver metastases, multiple bone metastases. So even though clearly single-agent checkpoint inhibitor makes most sense in this patient population, there are a group of patients where potentially chemo-IO may provide some advantage. Dr. Mock mentioned about TMB, and as he showed in Keynote 42, again in a retrospective subset analysis, analyzing TMB on tumor samples, there did appear to be a survival advantage in patients who had high tumoric TMB. But a similar analysis conducted both in Keynote 189 and Keynote 407 did not suggest a difference in outcomes. So it is possible that tumor TMB may not be a sufficient biomarker when evaluating chemo plus immunotherapy. So this is data with Keynote 189, and this is data in Keynote 407. And again, retrospective subset analysis, not all patients' tumors were available to conduct this analysis. Nonetheless, there does appear to be evidence that maybe chemo-IO is beneficial in both subsets. And again, there is this issue of STK11 and KIP1 mutations, and Dr. Skolidis from MD Anderson and others have done significant analysis that has demonstrated that patients with mutations in these genes may not benefit from checkpoint inhibitors, both when given as single agents and when given with chemotherapy and immunotherapy. These mutations are more commonly seen in non-squamous patients, though KIP1 mutations can be seen in squamous patients. At least looking at retrospective analysis of Keynote 189, what was seen is that there is benefit in patients whose tumors are STK11 mutated or KIP1 mutated, but clearly the benefit with chemo-IO over chemotherapy is much less as compared to patients whose tumors are wild type for these genes. And again, when you look at overall response rate, there does appear to be some benefit with the combination, and therefore I believe that at this point, these genes don't necessarily deter me from utilizing chemoimmunotherapy. Having said that, these mutations clearly have relevance when regards to choosing immunotherapy, particularly in patients with KRAS mutations. It is quite possible that these co-mutations may determine the type of therapy that one would use, and possibly there may be a greater reliance on using, in the future, KRAS G12C inhibitors may be combined with chemotherapy rather than immunotherapy as frontline treatment in patients with these co-mutations. And at the end, I wanted to finish up by talking about angiogenesis and checkpoint inhibitors. Clearly, we need to move sort of beyond chemoimmunotherapy or single-agent immunotherapy. And angiogenesis inhibitors definitely made sense. From a practical point of view, anti-angiogenesis agents are being utilized in non-small cell lung cancer. But interestingly, there does appear to be overlap between anti-tumor immune response as well as the angiogenic response observed in tumors, in that angiogenic factors may sort of downregulate anti-tumor immune response by both reducing sort of dendritic cells activity and enhancing the effects of tumor-associated macrophages as well as regulatory T cells. Interestingly, anti-tumor immune response or lack thereof may also influence tumor angiogenesis, in that cytokines released by effector T cells may actually have an anti-angiogenic effect, whereas cytokines released by Treg cells or tumor-associated macrophages may actually induce tumor angiogenesis. So there's a great deal of overlap between these two pathways, forming the basis for evaluating the addition of anti-angiogenic agents with immunotherapy or chemoimmunotherapy. And the first study to do this, as is well known, was Empower 150. This was a 3-arm study that looked at the sort of the standard arm of carboplatin, paclitaxel, bevacizumab, a regimen that was routinely used in the past, and evaluated either chemo with atezo or chemo, atezo, and bevacizumab compared to this standard regimen. And the only comparison that demonstrated survival advantage was the 4-drug combination of bevacizumab plus chemotherapy and atezolizumab as compared to chemotherapy and bevacizumab. And interestingly, at least in this trial, chemotherapy and atezolizumab did not demonstrate survival advantage. And therefore, this sort of study laid the foundation of further evaluating anti-angiogenic agents in combination with immunotherapy or chemoimmunotherapy. And one such effort was lenvatinib with pembrolizumab. There are several other VEGF TKIs that have been evaluated in combination with immunotherapy. This was a phase 1 study with expansion cohorts in several tumor types, and it demonstrated that there did appear to be improved response rate as well as progression-free survival compared to single-agent IO in this study. And based on this study, several randomized phase 3 studies were initiated. We do have results from one study, and I apologize, I just copied this from the website from ESMO IO. This study was presented by Dr. Sozi at last year's ESMO IO in 2021. This was LEAP-007 that randomized patients to pembrolizumab or pembrolizumab plus lenvatinib in patients with tumor PD-L1 expression of 1% or greater. Now, what is important to note is that the combination did demonstrate improved response rate and did demonstrate improved median progression-free survival, but did not demonstrate a median overall survival improvement. And also, there was greater toxicity with the combination, with a grade 3/5 toxicity of 58%. And therefore, based on this, the DSMB recommended to stopping enrollment on the study and to unblind the patients. Now, this is a VEGF TKI. Whether we necessarily see these effects when combining with a anti-VEGF or VEGF receptor antibody is unclear. And at this year's ASCO, Dr. Recamp and colleagues from SWOG did present the lung map trial that was in the second-line setting of pembrolizumab plus ramucirumab versus patients receiving standard of care treatment, including docetaxel and ramucirumab. This was a randomized phase 2 study, so the data has to be viewed in that with that perspective. And this study did demonstrate an overall survival advantage with a hazard ratio of 0.69. But when you look at the progression-free survival, there was no benefit seen. And sort of my take on this is that there is definitely a subgroup of patients that derives benefit from the addition of anti-angiogenic therapy. And I suspect that that subgroup really drives the overall survival, and that probably is a minority of patient population. And this is sort of highlighted when you look at the forest plots, that there didn't appear to be a benefit in patients who had non-squamous histology, or didn't appear to be a benefit with the combination of pembrolizumab, ramucirumab in patients who got chemo IO as opposed to patients who got chemotherapy followed by immunotherapy, making it quite important that it would be sort of important moving forward to identify the markers, whether clinical or pathologic, that can identify the group of patients that can benefit from this strategy. But clearly promising results that needs to be further evaluated. So what does this all really mean? And having sort of participated in Keynote 21G and Keynote 189, this is what I think immunotherapy is all about. This is a patient who started on Keynote 21, received chemoimmunotherapy. Those are the scans at the time of diagnosis in February of 2014. And 6 months later, there was no active evidence of disease on the scans. And the patient is still alive after having stopped treatment in February of 2016. Now, this, of course, happens only in a minority of patients. And I think the efforts of all the new drugs are to try and see if we can increase the proportion of patients that derive this sustained benefit. So in conclusion, chemotherapy and immunotherapy has now become the standard therapy for most patients with driver-negative advanced non-small cell lung cancer. Benefit is seen across all PD-L1 subsets as well as at least tumor-based TMB assessment, though it is possible that in patients with PD-L1 negative squamous cell lung cancer, strategies other than chemotherapy and immunotherapy may be beneficial. Benefit does appear to be less in STK11 and KIP1 and may have relevance in the future design of clinical trials, particularly in patients with KRAS mutation-positive lung cancer. And finally, anti-angiogenic agents in combination with immunotherapy are currently being evaluated with some promising results hopefully forming the basis of future trials. Thank you very much.
Yes.
Okay. So thank you very much again for giving me the floor to summarize the data with combos of IO plus chemo. And you see here my disclosure. And over the next few minutes, I really will touch a bit on those two issues, particularly the IO combos and the chemo IO combos. So then the first question is, do we really need dual immunotherapy regimes as compared to single agent or as compared to chemo plus one immunotherapy agent together? And while analyzing the available data with immunotherapy or chemo-IO, you see that there is some space. There are some unmet clinical needs. For example, as Dr. Mock already said, immunotherapy, single agent PD-1 inhibitors are pretty effective on a subset of patients. You may have a 25 to 30% survivorship at 5 years in those patients that are highest pressure, more than 50%. Indeed, looking at the data, some 20% of the patients are progression-free at 3 years. However, that means that there is some 80% of the patients that actually, even among the highest pressures, that are not taking much benefit at all from this type of therapy. So for those patients, we really need to do something, particularly in what is affecting long-term survival. Indeed, as been reviewed by Shiris and Tony, chemo-IO is effective strategy. We are able to really turn more immunogenic some tumors that do not respond to IO alone for sure. And indeed, you see some patients deriving even long-term benefit. It's been really highlighted by Shiris that benefit is really independent, is happening regardless the PD-L1 expression. That is true when you're looking at separation between curves. That is true when you're looking at hazard ratio. Of being progression-free in the long term are actually the highest pressures. Look at the negative expressors. At 3 years, nearly no patient is progression-free. So that means maybe you're benefiting, but not in terms of this new dimension of long-term benefit, which is something very attractive from immunotherapy. And this is not happening with chemo-IO, particularly in low or negative expressors. So for all those reasons, we believe there is some room for dual immunotherapy. And I'm just going to summarize some of the data that we have. Of course, dual immunotherapy makes all the sense. The more realistic combination would be inhibiting PD-1 and CTLA-4 axis. Those were the agents that enhance the priming on the immune activation with CTLA-4 inhibition. Then you could be more effective at the time of the cytotoxic response delivery by inhibiting the PD-L1, PD-1 axis. And of course, CTLA-4 inhibition may help as well to enhance again the immune memory, which may be of relevance, particularly in the long-term results. Actually, those data, those combinations are effective in some other tumors. Looking at the data, they really worthy in renal cell carcinoma. They are really worthy in melanoma. I actually think the data are the other way around. The left is melanoma, the right is renal cell carcinoma. Sorry for the mistake, but the truth is that the combination is working. And we have now the data chemo versus nivo versus ipi-nivo, and in negative expressors, chemo versus chemo plus nivo versus ipi-nivo. And as you see, as a primary endpoint in patients that were PD-L1 positive, there was a clear improvement in survival in the long term. And looking at the 5-year follow-up, we just presented at ASCO, there is a clear improvement, 14% as compared to 24% survivors at 5 years. But we have to highlight that the initial data are pretty close to what you see when you're treating an unselected patient population with immunotherapy single agent. You see that some 30-40% of the patients are progressing during the initial 3 to 4 months. And indeed, you see that this is impacting survival. The survival curves are actually crossing with chemotherapy in the initial 6 to 9 months. So there is some excess of death due to non-effective therapies for a subset of patients, even using dual immunotherapy, and that is an important point. Of course, the reason to have this long-term survivorship here in patients treated with ipi-nivo is because the quality of response is pretty good. For those patients that are responding, 40% of the patients, the response is maintained over time, and that is the reason why we are getting some plateau in the PFS curve as well. So the quality of the response on ipi-nivo may be underlying that fact. As has been mentioned by Dr. Gadil again, those patients with negative expression, even not included in the primary endpoint, they did benefit as well from this therapy. At 5 years, 7% survived with chemo, 19% with ipi-nivo, which I would say is really interesting data, particularly in this bad prognosis population. And again, the quality of the response is underlying those results. Of course, you're having more immune side effects. You're having dual immunotherapy as compared to single agent. 20% of the patients requiring dose continuation on ipi-nivo, and of course, you're getting more side effects, particularly hepatitis, pneumonitis, endocrine type of side effects, GI, colitis, and so on, and even more rare side effect when using ipi-nivo as compared to PD-1 inhibition alone. I have to really mention here that there is another trial comparing pembro versus pembro plus ipi in the highest pressure population in patients that were PD-L1 more than 50%, and there was not a clear improvement in the outcome. Unfortunately, maybe the trial was stopped pretty shortly, pretty early, but again, looking at those data, it's unrealistic to think that even if the trial would have been continued, you have found a significant effect on the long term. Some other IO combos are already there as well, and the combos with atezo plus tiragolumab in highest pressure had promising results in the initial phase 2 trial. We have seen a press release saying that the trial, at least in the interim analysis, was negative at the first interim analysis. We didn't see the data, so maybe better not to speculate too much on that. Let's go to the chemo IO combos, which should be the important body of this presentation. And of course, based on the 227 trial that you may recall, where there was an initial number of patients that had early progressions, the hypothesis of this trial was by giving 2 courses of chemotherapy, you may prevent early relapses and hopefully maintain the stable plateau in the long-term PFS and OS curve. So patients were randomized, squamous and non-squamous, patients stage 4, chemo-naive to receive 2 courses of chemo plus ipi-nivo for up to 2 years, as compared to 4 courses of chemotherapy. Primitive cell maintenance being allowed in the 2 arms of the trial as well for non-squamous. And as you see here, the primary hypothesis was really fulfilled. Those patients treated with 2 courses of chemo plus ipi/nivo, they didn't have this early progression rate that we were seeing with ipi/nivo alone. And indeed, if you look at the difference in survival at 1 year, that difference is about 16 percentage points. That was only 7 percentage points when you analyze the 227 trial. So the initial hypothesis was true. What about the long-term effect? Well, I don't think we have long-term effects as today, but the trial is positive, has a ratio being in the range of 0.7, 0.74 at the 3 years update just presented at ASCO. And I think it would be nice to have even some 5-year follow-up to see how are the data behaving with longer follow-up. Today, we can say there is a sustained benefit. Still, data are immature in the long term. We just can't talk in the 2-year and 3-year follow-up with confidence. Truly all patients were benefiting, maybe not the never smokers or those that were very old, more than 75, but that was true regardless of histology. Actually, squamous were doing particularly well. That was independent of PD-L1 status, as you see here as well. And PFS response and duration of response was also aligned with the survival data in favor of patients treated with the 9LA regime. And this is somehow satisfactory. Important, patients with brain mets were benefiting as well. Maybe in this subset analysis, secondary analysis, were even benefiting more than the patients without metastasis at baseline. And of course, again, TMB is not a good biomarker. It's not telling us which patients are benefiting from chemo IO as compared to IO alone. You see there was some difference for high TMB patients in favor of 9LA regime when in high TMB cases for PFS, but that was not true for OS, where all patients high and low TMB were benefiting. We just presented at ASCO again the same analysis based on mutational status, P53, KRAS, RKB1, and so on. I don't think there is a clear prediction. 20% of the patients, 22% actually had to discontinue, more side effects, particularly immune-related, less toxicity due to chemotherapy as compared to the control arm. This is, of course, expected. Only 2 courses of chemo were given in the 9LA arm as compared to 4 courses on the chemotherapy arm. Those patients that required to stop treatment because of side effects, they didn't do any worse as compared to the overall population, I would say. And that is quite a standard finding in immunotherapy trials. And quality of life is not being deteriorated because of the use of dual immunotherapy plus chemo in this regime either. There is another trial of interest, which is the Poseidon trial. Chemo plus treme plus durva as compared to chemo alone. There is an intermediate third arm where chemo is combined with durva. And you see here, the trial was positive for the chemo IO combo in the overall population, but in the subset analysis suggested that the benefit was mainly taken by the non-squamous histology patients. And as you see here, where the difference is more there. However, the squamous histology, they were not benefiting at all in this subset analysis. This is relevant because we have the 2 other trials, 227 and 9LA, suggesting those patients that were PD-L1 negatives, and particularly with squamous histology, were benefiting the most. Those data are not validated here concerning histology, and it's important to be highlighted. Here, again, quality of life is not deteriorated based on this treatment. Indeed, time to symptom deterioration and symptom control is better on the chemo plus IO arm as compared to chemotherapy alone. Well, we have mentioned here mainly dual immunotherapy plus chemo, always with PD-1 inhibition plus CTLA-4 inhibition. There are many other ways to enhance the immune system, and there are some other checkpoint inhibitors that are being used. And I'm just putting some examples of things that we are testing at present. And of course, one is the anti-TIGIT compounds. You see here, for example, the skyscraper OSIS trial where chemo plus atezo plus or less tiragolumab is being tested on this phase 2 study. The same concept is being studied as well in the skyscraper 02 trial. In that case, in small cell lung cancer, as you see here, and presented by Dr. Lydia Anasco. Unfortunately, the curves of PFS and OS were really super impossible, so no benefit at all, not benefit even on a small subset. Some other drugs, such as monasilumab and oleclumab, the CD373 inhibitor or the NKG2A inhibitors, are being combined with durva in patients that have received chemoradiation as well. So not only chemo-IO, but chemoradiation plus IO being studied in the Pacific 9 in patients that are having unresectable stage 3 disease. And even in earlier stage, the no-cost is testing chemo plus IO with durva and oleclumab or monalizumab in this phase 2 trial on a pick the winner phase 2 trial. Just to finalize, of course, LAG-3 inhibitors also important in this context. You know, the data with relatlimab in melanoma and studies of chemo plus nivo with or without relatlimab are also being performed in the setting of stage 4 disease, and even in earlier disease and trial being studied. Of course, I just put some examples here for our LAG-3, anti-TIGIT, and other compounds, but there are many other agents in the class that I don't like to be too repetitive. So, I mean, taking into account, I just to summarize the data also presented by Dr. Mark and Dr. Gadil. At the end of the day, we have a number of alternatives for patients that are without oncogenic addition, without genomic aberrations that are suitable for targeted treatment. IO immunotherapy, particularly for high expressors, chemo-IO, IO combos, and even chemo plus IO combos. I think at the end of the day, we may choose what is the best fit for each patient depending on the patient characteristics, particularly health status, convenience or not of using chemo, comorbidities, convenience, but also patient expectation. What is the patient betting for? Increasing survival, not increasing survival, but long-term survival, etc. But of course, the tumor characteristics, PD-L1 expression is not telling us all the truth, but it's a very important determinant of the outcome. Genomic background, how is clinically behaving the tumor burden, is the patient too symptomatic, is deteriorating the health or not? I think all those data compilated all together is helping us to make the decision at the end of the day. Take-home message, I think IO and chemo-IO regimes are alternatives for patients with non-small cell lung cancer. I'm not sure we have the best selection biomarkers to see which are the patients more, let's say, better candidates for that. Maybe squamous cell carcinoma patients, low expressors for sure. What is the best setting? Only advanced stage? Is there any role for those quadruplets, for example, in the neoadjuvant setting? And I think future evaluations should include other IO agents as being investigated, anti-TIGIT, LAG-3 inhibitors, CD73 inhibitors, and so on. So thank you very much for your patience, and be happy to answer any comment or any question you may have. Thank you very much indeed.